Dr. Mulbach, I think building from that, sometimes the social determinants of health are actually driving the actual diagnosis and or problem, a reason that we're seeing a particular patient, or that, as you said, they're maybe having trouble moving forward in a given area. And so, harking back to what you said about knowledge being power, I know over lunchtime, sometimes it's not so easy to participate, but even if you throw it into the chat, how often are each of you, including Z codes in your daily notes? If you're seeing a patient for generalized anxiety disorder, I'm just going to throw that out there. How often are you adding the psychosocial factors or, ACEs, like personal history of abuse, right? Those things matter. And the more that, generally speaking, oh, such a good point for me, Hurley. Thank you, Dr. Thompson, for being honest about that. I think we do miss them. The coding of them, generally speaking, is increasing over time within healthcare, but it's still a very, very low number. And so, if somebody is losing weight unintentionally, we could do a very expensive diagnostic workup, very thorough, expensive workup, without recognizing, they just can't afford, they cannot afford food to keep them at a healthy weight, which totally changes our intervention, to be clear, right?
I think we also need to consider the lens in which the physicians that we're working with, that they're working from. Dr. Beck, I spoke with her this week and she sent a lot of really great resources, and I'll put those in the chat as well. But one of them talked about how med students are educated about social determinants of health. And Dr. Lee, you could probably weigh in on this as well. But a lot of it is more like, these are the things that you need to know, right? And not so much of, these are the things that need to be challenged and changed. And so they're aware of the list, but how aware are they of what the impact really looks like? And so if we know their lens in which they're working from as well, we can help fill those gaps as they exist, as well as advocating for better education as it exists in those spaces. And so I think that is oftentimes, when I think about a BHC role in our clinic, it's treating the patients with a different modality, looking at a patient from a different perspective. When I teach about that, I always say the patient's kind of standing there and there are a group of people standing around them. Everybody has a different perspective on what they can see and determine what's wrong. And they have to be able to communicate that from their perspective. And so we have to, for one, treat the patient with our perspective, but we also have to change the clinic, the culture in the clinic. We have to provide education in that clinic and use that degree to make positive changes.
Right, so leading by example. So if we're not coding those Z codes or, extra factors that might actually be really an underlying cause or contributing factor, we're not demonstrating our biopsychosocial spiritual approach that we want to model for our primary care colleagues. And yeah, Chelsea, you're right. They're very, med school is very biologically driven, right? It's not specifically a biopsychosocial model, obviously. They have an immense amount of detailed information to learn in a very short period of time. It's very intense. And so recently, for the sort of graduation exam that they have to take, EPPP, don't want to give anybody nightmares. They have started to include some questions related to integrated care. So a tiny percentage, but they're there.
I like the idea you talk about modeling, because we need to not just talk about poverty, but talk about oppression. We need to not talk about race, but talk about racism. not just sex, but sexism, not just homosexuality, but homophobia. Those are the conversations that we need to be happening. And I think that's the second level to this on how we can move that mark in the clinics that we're in, is having those conversations at the next level. And maybe talking about not so much social determinants of health, but social determinants of equity. That might be a place to start as well.
I agree. And I think too, like we were talking earlier this week, this has like been the week of integration for a lot of us. Like we were talking earlier this week in a group with students and discussing how important it is for us to educate providers. And so if something isn't resonating in our clinic, we can educate them. We can talk to them. And that's also how we lead by example. Because if we're talking and we're giving them words to use, especially many of them just say, I don't know what to say or do, so I don't ask about it, or I don't have resources to give them, so I'm just not going to assess for it. Because I think to your point, Robin, like their education and their training is like, if you note that there is an issue with something and you don't provide a direct like line for solving it, many of these things aren't solvable, by the way, right? But like for our purpose today, then it's like, why would I even bring that up? And I'm negligent in my care if I bring it up and I can't give you anything for it. And so I think there's a paucity of resources for providers too, but I think that's a really great opportunity for mental health care providers to educate their teams, help them understand where to find the resources, and then also give them the language and the confidence to talk to patients about those things.
Yeah, you're right. Resources are definitely important, right? It's sort of unhelpful to bring it up, note it, and not necessarily have a way to help, support, or improve. So certainly, finding out for our own clinics and local areas what the resources are to combat some of the inequities to the best of our ability. We have not come to the point that we can eliminate them, so to speak, or have eliminated them. I'm trying to think, something you said sparked an idea for me, Michaela, and now it's gone with the wind, but it will come back.
What came to mind for me when she was talking was why don't they think, and why make sure that we think this as well, that we are the resource. So sometimes we don't have resources in our community, but simply taking the time to listen to maybe the intersectionality of that and consider it and talk to the patient about that. You are a resource. And so it's never negligent to bring it up and ask the question, because you do have a resource. It's you.
Yeah, and it's interesting. I've seen providers code like non-adherence somewhat regularly, or maybe non-compliance is a little more punitive version of that. When if there were a Z code present, kind of describing poor transportation or inadequate transportation or inadequate access to healthcare, the picture of why they're not following through becomes much more clear and helps us decide, us meaning the treatment team, decide maybe where and how we can help. And so then one of the nice things about being psychologists, of course, is that we are trained in research and in program development and many other skill sets other than just therapy or behavioral health consulting. So in terms of getting interest or drumming up investment in the cause, anytime we can show return on investment, and we have people listening more carefully and more closely. So this, I know everybody is likely extremely busy in their clinic, but even just choosing a single factor and sort of doing a PDSA cycle and seeing what happens, what changes, picking a measure and seeing, if we develop group psychoeducation visits, you know, where there's a clinic supported way to get the client to the group, so to speak, or we use telehealth platforms to be able to get to the clients, you know, and we pick an outcome. If we can show improvement in that outcome, or, you know, and associate it with a decreased cost, then of course we're going to have a lot more support maybe for making some of these changes or diving into some of these areas and showing, you know, not only the impact on maybe the healthcare outcome, but decrease costs for individual patients, or like individual or groups of patients.
That brings me to screeners. And so I have a question for the group. What screeners, if any, are you seeing in the spaces that you're in that are identifying social determinants of health? And I've got some that I'm also going to put in the chat so that you have them to use going forward. But I'm curious if it's happening. Is screening happening? And if so, what screeners are you seeing? Feel free to unmute yourself.
I don't know if folks are familiar with the SWIC, but it's a fantastic tool for pediatrics. It only goes up to age 5, or I can't remember if it's 4 years, 11 months, or 5 years, 11 months, but it has it's a great tool that looks at development, parental depression. It looks at a number of different things, but social determinants are a big part of that. And I do think that's critically important when you're looking at young kids, because the social determinants of health for the family system are so important. So it gets at that. And I've seen some pediatric offices that use that really effectively to, you know, to trigger pathways. So if they have these questions that they get answered, it means they get this consult or this consult. So I like that one.
Can you put that in the chat so we can spell that correctly? Yeah, I would not have, so. I've thrown a couple of others for pediatrics that Dr. Beck sent along. One thing that I want to point out, so we think about social determinants of health, there's some main ones. So we have food insecurity, which is just limited or uncertain access to adequate food. We have housing instability, you're shelterless or unsafe housing conditions are part of this, inability to pay your mortgage and rent, frequent house disruptions, eviction, utility needs, difficulty paying utility bills, shut-off notices, access to phone, financial resource strain, so the inability to afford essential needs, financial literacy, it fits under here. Not using your medications because of the cost of the medications would fit under here as well, and benefits denial. Transportation challenges, so difficulty accessing or affording transportation, that would be medical or public. Exposure to violence, intimate partner violence, elder abuse, community violence, and socio-demographic information such as race and ethnicity, educational attainment, family income level, languages spoken. Race is actually one that a lot of people don't think about a lot when they think about social determinants of health. For some reason, it gets left off of a lot of screeners because it's normally just picked up, right? It's just picked up as part of their intake information. And so we don't talk directly about it, but it needs to be talked about. And so I wanted to point that piece out to make sure that when you're assessing that you're not forgetting it, because it might not necessarily be directly on the screener, because we're hoping that you're getting the social determinants of health you would get in a variety of ways. Because if you hand someone a big, long screener asking them all these things that are difficult to answer, that is not patient-centered at all. And so you want to be able to get them from the intake, little nuggets here from the intake, a little bit from the interview, and then maybe you have a short screener, 12 questions or less that you can also offer them. And those will be very direct. And then those questions have to be presented in an appropriate way as well. We had a situation, and I don't know if any of the interns would be willing to speak up on this, a situation in one of the clinics that we're in, where someone had created a screener that was identifying needs, and they were just asking the questions pretty point blank. And with what they were trying to assess for the point of the screener, all of those came out of a really good place for this person. They were really trying to improve the clinic. But from what I understand, the interns looked at this and immediately said, this is not patient-centered. That was the big red flag for them. It's not patient-centered. How can we ask these questions differently? And so you can create a screener that is specific to your clinic or specific to the needs that you're wanting to assess for. You can create it, but it still has to be done appropriately. And there are steps to do that. So for example, the person needs to be engaged appropriately. You need to have a relationship with the individual initially before you start asking direct questions that are sensitive. And you can start with a good intro, like, is it okay if we spend a few minutes talking about your experiences and priorities in your life outside the clinic that might be affecting your health? I want to acknowledge that some of the questions might feel kind of sensitive, so feel free to tell me if at any time you don't want to answer any of these questions. That's a great way to start. There needs to be empathy. You need to have some understanding. There needs to be support and focus on the strengths. It sounds like you've been working hard to make ends meet. You're clearly very, very resourceful and creative. And then there needs to be some kind of summarizing and action plan to let them know that you heard what they said, and this is our plan going forward. And you want to allow the patient to prioritize their list. Just because they've identified a need doesn't necessarily mean that they want your help with it. And so there may be several needs, especially kind of these needs tend to snowball, right? We have like, once we get to this threshold of like 5 or 6, we tend to have 10 or 12. And so there may be several, but allow the patient to identify what that priority is for them and focus there. And so when I say that you're the tool, you are the assessment tool, and you can use these questions and you can put together a screener yourself, but it has to be done appropriately. And so in your clinics, also make sure you're advocating for, if those things are happening, that they're being done appropriately as well.
I really appreciate that, Chelsea. I think that was all very helpful, because when we think so much about, the work that we do, I think sometimes, and I'll just own this, like I get stuck in a space of like, it has to be perfect. Or it like, well, if I ask about, all of this, then I have to make sure I ask about that. And if I can't ask about everything and be, sensitive to all things, then what's the point, or why, why bother? And, I also think that oftentimes I've heard people say like, well, we can't do screeners because it's not been like normed, or it's not, and it's like, well, we're not touting it as necessarily an evidence-based practice per se, but like it's so often what we're doing is an unstructured interview. And so it's kind of weaved into that. It's unstructured. And you spoke about interns, and I want people to speak up. I want people to put it in the chat, whatever. I am forever grateful for our interns, because they are constantly teaching us. And something that one of our interns brought to us this year is from FACT, and this kind of third wave kind of CBT things, and contextual interview. The contextual interview is something I had never heard about, and so asking people about like the way that they describe it is like love and work and play. And it hits upon those things, Chelsea, you were just speaking about, like the living situation, the relationship status, who's in their inner circle, the religious or spiritual kind of beliefs, their social groups, their recreational kind of thing. And not just their current recreational things, but their historical recreational. So like, what did you used to do that you no longer can do or can't afford to do? Like, I had a patient once who was like, I used to love to knit, and knitting was so relaxing for me. And she's like, and then I'm on disability, and I can't afford to buy the materials. And, that was really hard for her. And then it also speaks about like their health, sleep, sex, exercise, all of those things you mentioned too. and caffeine, drugs, types of things, substances. It also asks about like the time, the trigger, workability. And that last one, I think, is just the ticket. What have you already done? It's so solution focused, right? Like what have people already done? It's one of my biggest pet peeves. And I've got a lot. Like I got a long list. I'm pretty persnickety for those of you who know me. Some might call it neurotic, whatever. Anyway, it is so frustrating for me whenever we hear, and we do it too. It's not just primary care, but like bad patient. Like the patient didn't do what I said to do. Well, they're not, of course they're not better. They're not compliant. And Chelsea and I had a conversation this week. I'm like, oh, that word, it's just like, adherent. A patient chooses to engage in certain behaviors. They're not being forced to. And we also need to take into consideration the context, hence the contextual interview, right? Like, what is the context in which this person lives and breathes and works and plays? What is the barrier to them? Like Chelsea mentioned, like if their medication is too expensive for them, not that they're choosing not to do it because they're not being compliant. And it's just a reminder. I think it's like such a general reminder to me. Well, I'm not being very general about it, am I? But I'm trying, to remind people about that, including myself. And I think that we could all use grace. And I think that's what the contextual interview for me is. It's like, it's giving people grace and space.
You just mentioned inequity being perpetuated by the clinics and the way that patients are talked about. And that brings up another factor for me. That is so common in lots of clinic spaces because we sit in a very public space in a clinic. And oftentimes you hear things that are really hurtful. And there was a study that I read about yesterday where a group of med students had gone through a particular clinic where there was a lot of discussion about shelterless individuals. And they had actually did a pre and post test, and their perceptions of shelterless individuals was significantly more negative, even just having passed through that clinic for one rotation. And so it changed the way then they provided treatment. And so we talk about, be an advocate in our clinics. Small things make huge impacts. And if we can change the language, if we can stop those things when we hear them and change one person experiencing that, who then goes on and has a lifetime of treatment with individuals, those ripples are huge, huge waves. And so what I would pass forward is do not underestimate what a small statement can make or a small change in a clinic. It can change generations of people. And so we should always be doing the small things.
Small things. Well, along those lines, Dr. Gillum, this is not the same study, but it just prompted something that I'd read recently. Again, it almost sounds unbelievable in terms of the difference that it can make. And I'm not sure how familiar or unfamiliar, as we're discussing social determinants, people are in terms of like, how do those factors actually look and what kinds of disparities do they actually contribute to in terms of healthcare outcomes? That being said, one recent study took 30 in a known sort of zip code area of shelterless individuals who were also a racial minority, and provided housing for 33 people within a 6-month time span. Now, I want you to hear this number. The saved healthcare costs were $1.3 million for 33 people across 6 months. So that came in the form of reduced emergency room visits and hospitalizations. So clearly, there's something about being shelterless or about having substandard housing, if just in case we're not explicating that sort of connection where children who grow up in substandard housing will have higher rates of asthma. Like the materials that are used in the built environments are different. There's more mold, there's higher levels of smoking. So, I'm not sure if we kind of made that connection between what the determinants are and how quite literally they impact health. Yeah, those are some good examples. We house a fourth of the world's prisoners. We have the greatest gap in mortality rate, within a single country. We don't have much of a middle class. We have the highest hours worked in the nation. So, compared to the rest of the world, sometimes it's surprising to remember that the US has things like the highest infant mortality rate, highest homicide rate. Is probably pretty easy to swallow in terms of our awareness of it. So, yeah, Chelsea, I appreciate you putting those more specific pieces of data there. And as I was saying, sometimes we can impact on these if we can find a target population or a high need in our specific clinic. Michaela, you mentioned earlier, using evidence-based, and some of this is in development, and not everything is 100% evidence-based just yet. So I don't know, again, how many of you or your clinics focus on healthy people goals, if that's something that you're familiar with, if you've all heard of healthy people, which is it's a 10-year, every decade, the Department of Health and Human Services puts out new goals and objectives. It comes under their moniker of Healthy People. So Healthy People 2010, Healthy People 2020, Healthy People 2030 and these are all data-driven outcomes, right? So that's important to remember. So for Healthy People 2030, the focus, the priority area is actually on social determinants of health and reducing healthcare disparities, which is amazing. So if you're interested, if you check out the Healthy People 2030 site, because SDOH is a huge focus for these, let me give you an idea of like specific kinds of goals they might, or objectives they might set. So they sort of they group social determinants of health into 5 broad categories. Dr. Gillum gave us some very good specific examples. They kind of say economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. And then lots of specific objectives under those. So I pulled a sample. So for economic stability, some of the general goals by 2030 are reducing the proportion of adolescents and young adults who aren't in school or working, right? And so they give these very specific objectives, provide national data and lots of resources for you, me, us, our clinics to engage in our own version of trying to meet these objectives. Like I talked about, maybe picking a specific area that impacts our clinic very heavily or disproportionately. And there's a huge amount of evidence-based resources attached to each of these objectives. So there are studies, there are handouts. So I would encourage you all, if you're interested, to there's community rollout efforts. Like they make it easy for you if you have the time, energy, or intern that you can assign that to. Just kidding. But there's a lot of resources there.
We have so much time and energy for thriving. I just think too, I really appreciate that, Robin. And, I think about ethics and diversity are something we strive to discuss in these conversations. And this entire conversation, I think, is about diversity, right? Like, it is certainly focusing on the things that make each individual person an individual person, and then meeting them where they're at. You are so correct about like linking those things. Sometimes it's death by 1,000 cuts, right? Like, it's you know, when you have those barriers, when things start to stack up against you, you can't access this, you can't do that. There's a barrier here and there and everywhere. And before you know it, I mean, apathy becomes something that is a reasonable response at that point, right? Like that is a like socially and culturally appropriate response. And learned helplessness, yes, thank you. And Seligman, another EPPP encouragement. But I think too, it's just like ethically, isn't it our responsibility to know these things? Like, isn't it our responsibility to not just know the EBPs that we're using, and we know like, okay, I've got a like smoking cessation. This is the manualized treatment for that. I think that's important. Like, it's our ethical obligation to understand each patient and meet them where they're at. It's justice. It's providing the same access of resources that we can offer to everyone, and trying to go where patients are, and trying, I mean, that's part of the reason why we see so many efforts. I love learning about that, Robin. Like, I'm so excited to look into that. It's like, that's why we see so many efforts from either grassroots, state, or federal programs to go into these spaces where people aren't. School-based therapy was a response to people who didn't have, like, their families literally don't have access to resources to get them to a clinic. And so it's literally, it's an ethical obligation for us to understand these things. And advocacy, you know, going and figuring out what are going to be the platforms that we as mental health providers are experts in and understand and see firsthand, and then how can we advocate and how can we go forward and make movement for that. Kind of a shameless plug for MOPA as well, like, you know, like getting involved wherever you can. And I think, Robin, you're spot on. We can't do everything, but focusing maybe on one thing could be something that becomes a snowball. And then referencing your lovely little quote earlier, I love that, like the small things can change generations of people. If you don't feel inspired after this panel, y'all, I don't even know.
I want to pause for any questions or feedback or additional information anybody would like to provide. This is impacting us all, so I'm sure you all have something to say. I'm going to put an adult screener in the chat. This toolbox provides a free screener that can be used. It's short, but it also provides you additional questions that can be added in for like optional social determinants of health that you'd like to screen for. So I hit the highlights, but there's also childcare, education, employment, health behaviors, social isolation and supports, and then behavioral and mental health. And it tells you like where the question actually came from, what grade level it's written on, because you want 5th grade and below, right? So those are things that you have to consider if you're picking questions off different screeners to create your own. So this will help provide that information. It also gives you alternative screeners, and I'll put those in the chat as well. But it's in that toolbox. But the Prepare, the Accountable Health Community Screening Tool, and the We Care. Has anybody used any of those? I'm familiar with the Prepare, but that's the only one I'm familiar with.
I have not been using these. I'm glad to see them, and I mean, I saw them previously, but questions. But I think I tend to gather that information more, as Dr. Milbach was saying, in a functional assessment and a contextual interview. You know, often asking about what gets in the way of certain things versus, you know, why aren't you, so to speak. Kind of the assumption that everybody is trying to do their best, you know, DBT type assumption, or everyone is doing their best. And there are probably barriers out there that make it difficult. I mean, I have a personal barrier of I need to take PTO if I want to go to the doctor during the day. It's not like these things can impact on everybody. It's not just the marginalized populations, and who we think of as marginalized sometimes needs a little expansion. Rural individuals living in rural areas are marginalized or underserved populations, right? Race, ethnicity, immigration status, health literacy. I think Chelsea, you mentioned financial literacy. These are very, very broad categories. So I'm kind of curious, just for fun, maybe. I mean, Michaela, you mentioned being a nerd. I mean, this is my idea of fun. And to make sure people are still awake, even if their cameras are on. I'm going to give you a quiz question. You can just throw out your answers or put them in the chat box. Okay. Number being between 0 and, let's say, 30. What is the greatest difference in life expectancy between counties in the United States? If that question makes sense. So if I were to pick the county with the longest living, okay, we've got a 30, 20, getting there. We're going high here, 25, 35. Kristen's like, I'm not going to keep your rules more than 30. Yep, Mark, you think I'm trying to trick you, huh? So I appreciate where you're coming from. I think you know the answer is going to be high. It's a little lower than our guesses. Okay, fine, 8. So somewhere in the middle, Dr. Thompson, good job. It's roughly 15 years at this point. And sometimes these are counties. In fact, we can narrow it down to zip code in terms of who lives the longest. Now, there's something fundamentally flawed in a system where zip code, so we're not talking about biological factors, we're not talking about genetic inheritance, we're talking about a number that indicates where on this globe you live, being one of the primary determinants of how long you get to live your one wild and beautiful life, right? So 15 years between counties in the same states, meaning, wealthy communities tend to average life expectancy into the 80s, whereas some indigenous populations, African-American or Black communities, barely scratch an average age of 60. So pretty big difference there. Thanks for playing.
Jarring, but also so valuable for us to know and understand. I think it kind of harkens to the long-lasting research that people with severe and persistent mental illness tend to live 20 years less than their counterparts. So again, I think that these are all ethically important for us to understand, but I would also add that this was shocking to me. So the value of having, these new kind of committees and things like that, work groups in our state, is that we start to really peel apart and look at things that haven't been looked at in a really long time. So Robin, whenever you mentioned the zip code, that reminded me, there are still several counties in the state of Missouri that do not have a 911 phone number link. So 911 is a general call number, right? We call that number, but there are several counties that still don't have access to that particular resource. If you think about that, in our most emergency situation, we can't access that. There are certain counties that don't have internet access in the state of Missouri. There's certain, counties that don't have, we think about Flint, Michigan, right? That they didn't have safe drinking water. Again, I know that we're speaking about really heavy stuff right now, but it is so sobering. I think that's a perfect word for it, Chelsea, because it's this is what we mean about privilege. We don't even think about so many of these things. And social determinants of health, where you live, make such an impact. And then you say, well, why don't they just move? The same thing of like, well, why doesn't somebody just get out of a domestic violence situation, right? Like, why don't they just, because they don't have the resources. If we knew better, we'd do better. If we had the resources, we would do better. So I think very, very important for us to remember and advocate. We are advocates for these individuals who may not feel like they can speak up.
Yeah, and that, I mean, that could really lead to an interesting discussion, and I don't know how time-wise or how active people feel about that. But I think, I really identify myself as a social justice advocate. And I'm not going to get into like specific politics, but we've kind of referenced this broadly that, systems are built to favor people who are already wealthy and who are already in power. And those are just facts. So if you disagree with me and want to have an in-depth conversation about it, we can talk more about it, maybe not in this space, and talk about some of the resources and figures and studies that support that, that it's not just a thought or an idea. So some psychologists are a little bit hesitant, I might say, to take on that additional title of like, I'm a social justice warrior, I'm a social justice advocate. And they don't necessarily have to. In behavioral health, in integrated care settings where most of us are, if we want to improve the wellness of our populations, we are going to have to at least accept those numbers or accept the way that built systems don't necessarily serve others. Michaela, you mentioned even just communities without internet access. So, one of the few good things maybe that have come out of the ongoing pandemic is how much more space we've been given to use audio visits, telehealth visits. That has been amazing. If you don't have internet access, you can't afford it, or it's not built into the place that you live, it doesn't do much for you, right? So many things that can be taken for granted really get in the way for people being well.
You just hit on something that reminded me. So part of the reason that we see a lot of education systems shying away now from talking more in depth about social determinants of health is because people have a perception that it's political. And so we talk about equity and we talk about power dynamics and money, it becomes politicized. And so there is a lot of backlash for educational organizations that do that. And so what we see is a shying away from it. And now we have a lot of individuals who don't have a proper education in order to advocate in their spaces. And that's really scary. One thing before we go to that I'm gonna see if I can screen share this. Has anybody played the game online called Spent? Yay, Melanie, I see a hand. Okay, let me show it to you then. Let's see here.
We use it for our Center of Interprofessional Education with med students and pharmacy students and nurses and OTs in their first year.
Yes, that's amazing. All right, can you guys see that screen? Are you seeing Spent? Yes. Okay. So here's the website, it's playspent.org. Dr. Beck passed this on. She said, this is great for like, I don't know how Melanie, maybe you're interested on how you guys do this, but you can do it individually, but you could also do it as a group, like have the group lead you through the decision-making and talk about it at the same time. So if you have individuals who want to educate on social determinants of health, this is a great thing for them to do. Or if you have students, encourage them to go through this process as well. But once you go to the website, you can click on this, and then it gives you a lot of really good information as you go along. And so you have these decisions to make as you go through, and then you see how long you can survive. I've done it a few times now, and it's a little different each time. So it's relevant to even do it more than once. And I've tried different things to see what the outcome is. The questions are fantastic. And like I said, if you're going to choose a job here, they've got options here for, you can smash your kids' piggy bank and get 16 bucks. You can donate plasma, or you can get a payday loan. And there's consequences for all of the things that you do. If you have to take off work, you get strikes. If you lose your job, that impacts your balance. But you just walk through these big decisions. So we chose a job. And now you've got to pick an insurance plan. And so then here it provides you some education as you go along. So highly recommend this.
It's like the Oregon Trail, but 2022 healthcare version. That's awesome.
Yeah, it is. It is. So great thing for students to do. If you haven't done it, it's a great thing to do. Wonderful. I think that would be probably the ideal way to do it. And then talk about what decisions you made, why you made them, and how it impacted you to make them.
And what was the hardest decision to make? I think that was really impactful for the students, because sometimes it was like not giving money for a field trip was just really hard because it was only a couple of dollars, but I couldn't do it with the rest of my expenses.
I got one where there was $10 in a birthday card to my child. Do I take it or do I give it to my kid? And the kid ones got to me. There was another one where I was able to pick up an extra 50 bucks to do something, but it landed on the same day as my kid had a play. Do I go to the play or do I do the job? Oh my gosh, I can't even talk about this. Difficult.
And just, pulling that kind of back around, it just fits so well with what you already mentioned, Dr. Gillum, about, the sort of the cycle or the way that these factors can just continue to build on each other, right? So people who, don't have access to resources, they enter the system, the healthcare system later, their disease progression is further along, they're kind of starting behind, so to speak, through no fault of their own. Nobody kind of wakes up and says, I want to live in poverty today and, not take good care of myself, and etc. So back to that idea of this not being political per se, maybe it's political in terms of how do we go about reallocating resources, but the fact that there is an unequal distribution of resources is fact. It's just fact. So Cole had asked, I think, was it Cole? Are you still here? About, talking to students, and some of us popped in there and put some ideas into, how and what you can do for advocacy, or learning how to be an advocate, and kind of, oh, there you are, Cole. So you're right in front, you're like, if you were a snake, you would bite me. So I think that's a really great question. And I think, individual differences, as I mentioned earlier, genetics are not, maybe health inequalities are not things we can change, but health inequities are things that we can change and discuss. And, it is important for us as behavioral health consultants and psychologists to self-reflect. And so even taking a moment or many moments to look at your own biases, your own assumptions, educating yourself about and one of these social determinants that maybe you didn't realize was or is important in terms of impact on generations, right? And looking at your own potential biases so that you're not overlooking things that are very important for somebody's wellness.
I would agree. I'm a huge advocate for just speaking up in all the spaces that you're in, whether that's a family dinner table or it's the clinic you work in. And then every time that you think that you get it, you will embarrass yourself and realize that you don't. And so to keep digging in those moments. All right, we are at the end of the hour. I appreciate you all being here. Again, like we could have done this for an entire weekend, right? Thank you for being here, and we hope to see you next month. Have a great weekend. Bye-bye.
Thank you, everybody. Good to see you all.